So what is unique about cortisol action is that cortisol is basically a glucocorticoid. It's a lipophilic one, so it can easily cross the membrane and it will work via the intracellular receptor, which are present. Once it binds them, it dimerizes and it dissociates from the heat shock protein. And this basically then goes into the nucleus, where it will act on the hormone response element, which acts like a transcription factor to initiate transcription of the protein. So what it tells us is that glucocorticoid action is going to be a slow process. But sometimes when we say steroids, we get immediate effect. How do we get that immediate effect? Because here we are saying you have to go to the nucleus, start the process, protein is being formed, but immediate effects are seen with cortisol. When you give injection hydrocort, immediately patients find good improvement, which is there. So how does that happen?
Okay, you have some memory.
Memory. So memory, how will it help? So one is the nuclear effect, but they also have a membrane effect as well. So a lot of these steroid receptors, estrogen has been shown to be, vitamin D has been shown to have a membrane receptor as well. So they will act on the membrane receptor to cause an effect as well. So that becomes important. Other than that, there is also a lot of action which is happening in which the whole membrane may be stabilized. So dexamethasone in particular has a direct effect in the cerebral area. So even before other actions happen, it will stabilize there. So that's why we use dexamethasone in high doses in cerebral edema, cytotoxic cerebral edema. So that is specific for dexamethasone. So that is the important function. Now, how do these receptors work? So we know that these are basically products which are acting in terms of the cellular production. And there are processes in which once they go there, we discussed when we were talking about physiology, about the activators and the repressors. So there are mechanisms which are there in the absence of a ligand binding, the production of these genes are suppressed. So there are co-suppressors which are binding and they inhibit the production of their product. Now, as soon as you have got the binding of the hormone ligand, these co-suppressor will go out and you will have co-activators which will come into the picture. And these co-activators will then allow the increased production. So what is the advantage of this repression, Dr. Dhwani? So why do you think there is, so in natural situation, it is repressed. Now you remove, it becomes activated. So why do you think this mechanism, how does it help?
Because the action of cortisol is in a long term, so when it is not needed.
Okay. The other way to think of it, that suppose you want to have a lot of gradient in terms of the effect. So in the absence of glucocorticoid, the production is actually inhibited. So it is below normal. And once you have glucocorticoid, level go really high. So this gradient becomes huge. That is why your responsiveness will be more. So this is a very interesting mechanism by which you are suppressing in the normal situation and increasing. Otherwise, if you talk about cyclic AMP, whatever you say, it just activates the pathway. No, nothing is, nobody is suppressing it. So this is unique also for these receptors. Now, do steroids only activate the production or do they suppress the production, Vibha, of any particular genes? Do you think they will suppress also?
I didn't get
like
that. Could you?
Do you think which will be suppressed directly? Cortisol will suppress what?
Cortisol, cortisol will suppress AVP.
Yes, ACTH, AVP. So of course directly. So there are many ways in which they suppress also. So they not only have a activation process, they will also have a suppression process which will happen. So there is a process of repression from which they will take off the repression and stimulate, and they will also suppress certain things. So same glucocorticoid receptor will work in a different fashion. Now, do we have different glucocorticoid receptors in different places?
We do have, yes, according to express tissue variation, we do have different kind of.
So there are different kinds. What do you mean when you say different types of glucocorticoid receptor? Are they structurally different?
Glucocorticoid is the same.
Yes. So as estrogen, we have ER, ES1, ES2, thyroid, you have got different alpha, beta. But for glucocorticoid, you got only single type of receptors. So it is going to be very difficult to develop selective glucocorticoid receptor modulators. So like estrogen, you've got things like tamoxifen, who will mainly act on the breast. You will have raloxifene, which is mainly going to act on the bones. So they are selective estrogen receptor modulators which are developed because of local tissue activity and other factors. But glucocorticoid, prednisolone, hydrocortisone will be the same, whether you talk about bone, whether you talk about muscle, whether you talk about fat. So there is no unique type of ligand which will act on one part. What are the effects of glucocorticoids? They directly have a growth suppressive effect. So they are pretty much opposite to what growth hormone does. So they are basically causing the growth plate to sleep. The advantage of this is that once you stop steroids, they will have a chance to grow back. That is an advantage which happens with growth retardation. They will affect the bone mineralization, and every part of bone mineralization is affected. Right from the formation of bone, to increase resorption, to decrease in calcium, to decrease in phosphorus, to decrease in 1-alpha hydroxylase, glucocorticoids are bad for bone. So every part of the whole pathway is affected in bones. They of course have a metabolic effect. So they are in a way catabolic hormones, so to speak. So they will increase gluconeogenesis. Your proteins will be lysed from there and it will be converted into glucose. You will have release of fatty acids, and you will have released of the adipocytes which will deposit in the liver. You will have abnormal deposition of fat causing Cushingoid features, and all those things will happen from that. And of course, you will have insulin resistance. Glucocorticoid will cause insulin resistance. They will have a suppressive effect on both cellular and lesser extent on the humoral immunity, but they will have an impact. Skin, they will have skin fragility, and we all know about bruises and other aspects, and HPA axis of course is there. So what about growth? So we already discussed that cortisol has got an adverse effect in the entire axis. It will suppress the growth hormone production. It will also have an effect on growth hormone action. So you will have growth hormone resistance sort of a state as well. So you have a combination of GHD and a combination of growth hormone resistance sort of a scenario. It's not complete GHD, but decreased secretion and action. So theoretically, if you give them growth hormone, they will respond. So that is why this has been tried in treatment of glucocorticoid-induced growth retardation in that scenario. Now, this I've already briefly alluded to, that they are bad for the bones. Now, what do? They have a direct effect on the osteoblast. And osteoblast, we talk about the pathways. We talk about the RUNX and the BMP pathway. These both are, BMP comes down, RUNX has activity. So osteoblast basically decrease. So you have decreased bone formation, which will happen. Now, on the simultaneous side, they will increase the rank ligand activity and they will decrease the osteoprotogerin. So basically what's happening is that your osteoblasts are going to go down and osteoclast will go up. So your bone turnover will go more towards the bone resorption rather than bone formation. And therefore you will have increased resorption. So you will have increased level of alkaline phosphatase and other markers, and you will have bone loss, which will happen. Now, which part of the skeleton is more affected by glucocorticoids?
So mainly the bone metabolic part, like vertebra.
So they are known as what type of bone? Trabecular bone. So that will be more affected as compared to the cortical bone. The other reason is that they affected is everything, but this you can pick it up early because they are more rapidly metabolized. So spinal, so lumbar spine, that is a typical fracture. So if you have a child who is long standing on steroids, complains of pain in the back, always get an X-ray for a lumbar compression fracture because they may be asymptomatic otherwise. Loss of height in older individuals, that will be another prime parameter which will suggest that you may have a lumbar fracture which is happening. Now, you of course have increased calcium loss. We know that steroids cause hypercalciuria. They have got renal as well as GI calcium loss. And there is also an effect on the phosphorus pathway because calcitriol is also affected. So it is a multitude of effect on bone. What about metabolism? I've already discussed that it is going to affect different pathways. In that perspective, it is going to have a hyperglycemic state. So you will have more gluconeogenesis. Muscles will be wasted, used in producing glucose. So you will have diabetes on one hand and muscle loss on the other. So it's like opponent of insulin, so to speak, in that regards. Now, of course, you will have other effects on the lipid metabolism. So hyperglycemia, fat deposition. So this metabolic pathway involves the enzyme CYP3A4, which is again a P450 group of enzymes, which produces hydroxides and glucuronides, which are then excreted via the kidneys. So if you have renal dysfunction, your urinary metabolites will not be appropriately excreted. So Dhwani, in a patient in which you have suspecting Cushing syndrome, if you have renal failure, which test should not be done? So you will prefer an overnight dexamethasone suppression test. That will be an important message from there. Now, drugs which stimulate the P450 pathway, predominantly phenytoin, rifampicin, phenobarbital, and carbamazepine, will cause increased activation of CYP3A4. So in patients who are on anti-epileptic drugs, which test should be done to diagnose Cushing syndrome? Dhwani. Vibha. So which cannot be done? Let's put it first. Which test should not be done if somebody is on phenytoin? So any test which measures the total cortisol. So ONDST, LDDST, HDDST, they will become unreliable. So you have to look for free cortisol, which you can get either from the saliva or from the urinary. So in renal failure, you should do a plasma-based assay, while on these drugs, you should do a free cortisol-based assay, which is filtered. Now, drugs like voriconazole, clarithromycin, and ritonavir inhibit this enzyme. So if you have inhibition of this enzyme, what is going to happen, Dr. Manoj?
So liver will be high.
So if somebody was on steroids and you are giving these drugs, you will become Cushingoid. So if you're using phenytoin, rifampicin, two effects I said. One is that you will be having a overdiagnosis of Cushing syndrome, because these drugs will be the cortisol, these things will be metabolized. The other thing which can happen is that your body, suppose somebody was on steroids and you start phenytoin, their metabolism increases and they will go into crisis. So this is very common in the setting of MPHD. But if somebody is on these antifungal drugs, you may suddenly have that the requirement go down and the patient may become Cushingoid in that regard. So this is something which is going to happen, which we need to worry. Now, so metabolism, basically we said there are multiple pathways. So you've got 11-beta-HSG2, which converts cortisol and cortisone exchange, which happens in that perspective. Then there are various enzymes like 5-alpha-beta reductase, which produce dihydrocortisol and cortisone, then 3-alpha-HSD. So finally, you have got these compounds which are produced, the cortols and cortones. In which condition would you like to compare the levels of urinary cortols to cortone, and you will get a diagnosis? So there is a pathway, as I said. So there is 11-beta-HSD in between, and then you've got 5-alpha, all those pathways there. But a lot of people used to do urinary excretion. So one is that they were looking at the urinary profile to get the diagnosis. But if you're looking at a specific scenario, a ratio of urinary cortol to cortone, that will give you a diagnosis in a child who comes to you with hypokalemia, polyuria, and failure to thrive. So which condition would this be helpful? And high blood pressure. I think there's nothing much else which is required. So of course, because if your 11-beta-HSD2 is defective, you will have mainly cortones which are there. All compounds will be less. So urinary metabolites also play a role. Now, we don't do much urinary metabolites now because now serum is much better. People used to earlier do ketosteroids and hydroxysteroids. So what did ketosteroids mean? So they are markers of androgens. Ketosteroid. Hydroxysteroids are more like cortisol and that. So that used to be done earlier, but now people don't do it. Some labs do a HPLC, which will give you the spikes of different metabolites in the urine. So that will help you diagnose some steroidogenic defect. But with genetic diagnosis, that also becomes a less important parameter. Now, 12-year-old boy with GHD on growth hormone, Dr. Manoj, lethargy and weakness. Now his blood pressure has gone down and sodium is also low. So what do you think has happened to this child?
Now could be it was associated with other hormonal deficiency. So with the hyponatremia, it is failing towards the hypocortisolism, or it is failing to the adrenal crisis. So
So you have to-
use the metabolism.
Yes. So growth hormone increases the inactivation of cortisol using 11 beta HSD. So clearly your cortisol level, as we said, 11 beta HSD may be affected via the growth hormone, and therefore you may have to be careful about that perspective. So you have to always exclude and treat cortisol deficiency before you start growth hormone. Everybody knows that, but often your dose requirement will go up also. You have to be careful about that. You can all go and have a look at our website, our courses which are available, and the mobile application. So